Incivility and bullying in the healthcare environment is our episode topic. My guest is Dr. Matthew Howard, Director of Scholarship and Leadership Resources at Sigma. Matt is also adjunct faculty at Northern Kentucky University and a staff nurse at both Ascension St. Vincent Evansville as well as Deaconess Gateway Hospital. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Matt, thank you so much for joining me today.
Thank you for having me.
Incivility and bullying are two words that are often used interchangeably. Are they the same, and does it matter?
There is a big difference in them, to be quite honest. So we'll start off with bullying, and then I'll talk about incivility. Bullying itself is a harmful, targeted, intentional, and repetitive act towards another, right? It is something that someone actually intentionally has the brain power to say, I'm going to be mean to this person for whatever reason is in their head. I am going to intentionally make their life worse. And that is considered what most nomenclature is related to what is bullying, period. Now, incivility is different. Incivility is a much more general term for behaviors that essentially lack good social manners. Incivility can manifest itself in many ways, from either subtle remarks to overt actions or acts of intimidation. These things include things like insulting comments, not giving credit where credit's due, perpetuating social isolation of others, interpreting others, failing to listen, and condescending or just negative gestures for people. We often talk about the eye rolling or anything like that. Those kinds of things are under that umbrella, that general term of incivility itself.
What I heard you there about some nonverbals, though, intention does not necessarily matter with incivility. Is that correct?
Intention can matter with incivility. I can be having a bad day and do something to somebody and they take offense to that. That's not necessarily bullying. That can mean that I'm being uncivil to that person.
Okay.
I can also be in a bad mood because you did something to make me mad. So I'm going to have some type of a negative reaction to you. Now, my intention may be to be mean to you because you are mean to me. That is part of uncivil behavior, but it's the difference between them becomes when there is a harmful, targeted intention and the repetitive acts. And I'm not talking repetitive acts as in you may be mad today, so I want to make your life blank today, but then tomorrow I forget about it and we're fine. It's that repetitive component and that harmful target that is what identifies as bullying itself.
Thank you for clarifying maybe the difference between the two, that incivility is much more broader. Is all bullying a form of incivility, or are they truly distinctly separate? In other words, if I were going to Venn diagram it, would these be two different circles, or is bullying a circle completely within the incivility circle itself?
No, I probably myself would put incivility within the circle, that umbrella, if you will, of incivility itself. Yes, I definitely put
Bullying
it
within the
that,
circle.
as opposed to Venn. Correct.
Okay. This is an interesting topic. How'd you get involved in this type of work?
I've worked around what I would consider bullies for a long time. We all have had individuals that we think are the bullies or are bullying type behaviors and stuff like that. Even given the definition that I just gave you, whether most of them probably are not actual bullies, but still what we considered bullies at the time. And I had a newer nurse that was quite literally being bullied by one of our charge nurses. And she was somebody that I had befriended and we were friends and talking to. And we essentially went together to develop what can we do about this, as opposed to being retroactive and really going after this individual and trying to be bullying to that person. What can we do to make it better? And we actually presented a poster presentation at Sigma's conference, Creating Healthy Work Environments in 2017. That is what spawned the thought process that we came to of that out of that poster that we looked at and said, this is what we would like to be able to do. This is what we would like to try to be able to do. That's what started my research in this particular area. And that's what's led to my doctoral work and the research that I'm still doing today. Because what I found in doing the lit review for that initial poster and then what I found in the subsequent lit reviews is that there's tons of information that is out there describing the problem. We know there's a problem. It's been going on. It's been documented for decades. There's very few interventional studies out there that actually show, does something work? And that's what I really wanted to go after. It's great to understand the theory and see the descriptive studies, blah, blah, but we really want to get down to what works. What makes sense? What can we do to make the issue go away? So what I really focused on is what is one intervention that I could find and that I could do that could really make a difference for that bedside nurse, like my friend? What is one thing that we could put in place that would make a difference for those individuals at the bedside? Not the whole sky of nursing itself, but for that one individual. And that's what we developed.
All right. So, what is the secret sauce?
From what I was able to find in the literature, the reviews that we did, communication is what came to me as the light bulb of what can make things easier and better. The intervention that we developed was an asynchronous educational content, asynchronous educational course that is solely devised around how to increase communication between providers, how to have those what we call critical or crucial conversations. How do you do that? How do you do that in the moment when the situation arises to let the other person know what they were doing and how it made me feel, or how it made patients feel, or how it was a negative act in general? That's what we put together. And we were able to show statistical significance that it did make a difference in individuals pre and post in that particular one. And I'm not here just to push that course by any stretch, but the education that we did was specifically related to communication. And if you know how to have that communication when the timing is right, when the timing is needed, you can ward off and change people's behavior. And that's to say that is not just to say it's just about me giving that education. I'm still learning this space as well. I had an instance a good 3-4 years ago now with a seasoned nurse. I was speaking to that nurse about something non-clinically related, and I was to this nurse coming across very condescending, very just rude, very mean. And that's how I came across to him. And he had the communication skills at that time. He was more seasoned than I was. He had the communication skills at that time to be able to say, Matt, you're talking to me very negatively, and I don't like it. And I'm not going to do what you're asking for me to do because your approach is not right. And he got up and he walked away. And it took me back because I'm the one out here trying to teach people about incivility, teach people about bullying, right? And then I get called out for being that uncivil person. So it's one of those things that it's constantly something that we all have to work on, because it's very easy to do that eye roll or that, seriously, I've told you 12 times and you can't remember this. It's very easy for us to go to that space, but it's something that we have to be cognizant of so that we can help individuals, we can help us know that what we're trying to communicate to them is X, Y, and Z, not the behavior or the emotion that we're actually showing them. And being cognizant of that behavior, being cognizant of what I'm doing, what I'm saying, and how I'm saying it, that in itself is a full-time job. But that goes back to learning how to communicate. to be quasi-fair, when this particular thing happened, I was still in this process of doing my doctoral work, but that doesn't mean to say that it hasn't happened since then. It's very easy, and that's why I go back to the difference in what is bullying versus what is incivility, because we can all have acts of incivility. We all have bad moments or bad days or bad times every once in a while. It's a matter of that repetitive act, that targeted harm, that intentionality that moves it into the bullying side of things. But the problem is, in nursing, incivility in general was one of the biggest things that is what nurses actually identify as part of their intent to leave, whether it's the profession, the department, the organization. It's one of the biggest things is that the civility in the actual department, the civility within the actual organization. And communication is what I have found, what I focus on, that really can identify and make a change essentially within people talking to each other and actually decreasing the civility period.
A lot of times when we're talking about education for staff, particularly around crucial conversations, there's a lot of hospitals out there that are offering that already, but they're offering it for charge nurses and emerging leaders, not necessarily the new grad or the person that's new to the unit or the staff nurse that's been there for 10 years. What I hear you saying is that this is content that is of equal value to someone that is operating at that staff level. So, how often should something like that be offered?
The study that I did, we literally looked at individuals within the first 6 months of hire at an organization, because I didn't want to put in the thought process of these people. I'm doing this study essentially and asking people if they've been bullied in the last 6 months or whatever, and then they've been conditioned, if you will, to be, this is the norm. This is just how nursing is, right? I wanted those individuals that were in their first 6 months of coming to the organization. So I had a control group, had a experimental group. Experimental group were people that were still in orientation, so still brand new. My control group were people that had been in orientation within that 6 month time frame. And out of all of those individuals, we found over 90% of those individuals had some type of incivility, some type of bullying behaviors that had happened within that 6 month time frame, okay, or within the time frame that they were with the organization. This is something that needs to be educated, communicated, dispersed, and it's not just a one-time take a course and boom, you're done. Just like I talked about with my example, it's something that I have to continually remind myself, stop the eye rolls, stop the comments, stop the little whatever under your breath kind of thing. And you always have to be thinking of that, because once we start doing it to each other, it's very easy to transfer that to the patient or the patient family. That's why bedside reports have started to becoming much more of a thing, because it gets us into the patient room, putting the patient, of course, as part of that discussion, but it also takes away the negative comments, that incivility that we have towards patients sometimes, or towards family members specifically sometimes, in room this or room that. Always being part of that conversation, always being part of that thought process to really make sure we're looking at and identifying and knowing what our triggers are, as well as what things we can do to decrease our uncivil behaviors. It's an ongoing process for all of us, but it needs to start at the beginning and it needs to be seen. So from a leader's standpoint, we need to be the ones that are doing this often, right? That are talking about it often and then projecting that. So if I see my nurse leader being rude, being what I would consider uncivil to somebody else, it's going to be very easy for me to continue to do that because they're doing it, so I can as well. So we need to be able to lead from that example, if you will. And that is in our charge nurses, that is in our management, that is in our administrative leadership, et cetera, all the way up. But it's not just in nursing, right? It's not just in nursing. It's anyone in healthcare, anyone in the organization. When we did the study that I worked in, I've worked in a couple of studies since then, and things that we're still finding out is it's not just nurse to nurse lateral violence, right? It's not just patient to nurse lateral violence. It's tech to nurse. It's secretary to nurse. It's rad tech. It's physician. It's advanced practice nurses. It's everybody within the organization need to be aware and cognizant of what we're doing to each other and how we're treating each other. It's very easy for us to be dismissive, right? It's very easy for us to be able to do those kind of things. But understanding and knowing where our good social manners are and really putting that first, not just towards the patient outwardly, but also internally. That's the big key.
You mentioned a patient earlier. And so I'm just curious. I'm sure the answer is yes, but the relationship that may exist between the presence of incivility and or bullying and its impact on patient care and patient care outcomes. Can you talk a little bit more about that?
Workplace bullying or incivility, as we're talking about, also coined as relational aggression by Dr. Cheryl Delaseda. That can significantly impact patient care and definitely patient outcomes. So when nurses experiencing incivility, they are less likely to speak up about concerns. They're less likely to ask for help, less likely to take necessary risks to promote or protect patients. This often leads to errors in judgment, missed opportunities for improvement, right? Identifying what kind of things can actually help patient care because they don't want to bring those things up, and even patient harm. In addition, the incivility or even the bullying itself creates a hostile and stressful work environment for us, leading to the burnout, turnover, and decreased productivity. So, some specific examples of things like that would be a nurse may be reluctant to report a medication error, fearing of ridicule or being ostracized by colleagues because they're just a stupid nurse. Nurse may not speak up about a patient's deteriorating condition because of fear of being blamed for the patient's decline, one, which does happen, or more accurately, not catching any real or imagined signs or symptoms that led up to it. So we get berated. Why didn't you check on this? Why didn't you find this? Why didn't you know this? Another one may be a nurse may avoid asking for help on a complex patient because they're afraid of being seen as incompetent, stupid. Those have huge effects, obviously, on patient care and patient outcomes. And that all stems from the ability or the inability to be able to have communication, healthy communication. When nurses are afraid to be able to speak up, when they're afraid to work together, it overarchingly decreases communication and collaboration, not just between nurses, but between nurses and physicians and techs, et cetera. This harms patient care, leading to errors and errors of omission, right? Prolonged acts of incivility between individuals, between techs, between nurses themselves, that increases stress. It increases burnout, like I said. It makes it difficult for nurses to focus on their work and provide the best possible care for patients. Nurses who experience that relational aggression are often more likely to leave their jobs, like I said, which can lead to staffing shortages, decrease in patient quality of care. It's often said that that people leave their positions because of management or leadership. And it sounds like I'm saying incivility and relational aggression are the culprits. But in this context, it's the byproduct of poor leadership. If leaders, we are okay with that kind of stuff going on in our units because either we don't think it's happening, we're not out there to see that it's happening. But from the staff nurse side of things, nurse leaders are letting it happen. This person continues to do this. They continue to berate me. They continue to be mean to me. And no one does anything about it. So it's accepted. It's okay to be that way. And that's what leads people to leave those positions.
So, if I'm a nurse leader, regardless of whether I'm at a charge nurse level, manager level, director, all the way up to CNO, what are some steps right now that I could take to promote a sense of community and collaboration among the staff that I lead?
One of the first things, of course, is being aware of the prevalence of incivility and bullying, within your nursing department. Research has shown that there's a significant percentage of healthcare workers who experience or witness some version of uncivil or bullying type behaviors. Like I talked about in my own research, nurses, and this of course was pre-pandemic, but nurses in that particular setting, over 90% noted that they had experienced some type of bullying, right? I experienced that on unfortunately a daily basis in my own clinical area. When I go into a patient room and try to do a patient assessment on a patient, and then I have an advanced practice provider or I have a physician that comes in the room, they just take over. They just start talking over me. And because they are the ones that are caring for the patient, so they just ram right over me. When I've had that conversation after the fact, obviously outside of the patient room, when I've had that conversation with those individuals afterwards, and I let them know the way that they were perceived, oftentimes, once they're made aware of it, they stop. They do understand that I didn't realize this is the way I was coming across. I didn't realize this is what I was doing. And I've had patients that have actually said, wow, he just started talking right all over you, didn't he? And of course, then how do you have that communication with a patient? How do you not say, yeah, that physician was really mean and blah, blah, but he's going to take really great care of you. So what do you say in that when that kind of a issue comes about? So it's really about knowing the prevalence that is actually happening out there, and then being able to possess the skills to identify those signs of incivility bullying and then intervene promptly. That's one of the biggest things that I would probably say. Creating an environment where nurses actually feel safe reporting these kinds of incidents are essential. Timely intervention can prevent the escalation. It can foster that culture of respect and support within the department, within the unit itself. There are training programs, again, that raise awareness to do that, to help people to develop those conflict resolution or critical conversation skills to be able to do those things. But really being able to identify and then intervene when we see those things, and giving not just the staff nurses the ability and authority to be able to intervene, but they've got to be able to see it from the leadership side of things. So one of the things that is really prevalent in the literature in terms of actually interventions is, and it went against my school of thought in the past, but as the research is evolving, it really makes more sense to me as well, that if you're, let's say, for example, let's put it in a clinical setting, you're a nurse manager, you're a nurse director, and you're in a staff meeting and you're talking about X, Y, and Z, whatever it is. But you're noticing some nurses on their phones. You're noticing some nurses talking to each other, just playing, not really paying attention. The school of thought in the past, of course, was you want to counsel in private and praise in public, right? However, everybody else can see that those individuals are doing what they're doing. And evidently it's okay to do that because no one's stopping them. It's that kind of stuff that nurse leaders have to have the ability to be able to point out and say, I see you're on your phone. If it's an emergency or home or something like that, if you guys could just go on outside, take it outside just so it doesn't disturb everybody. If not, could you please put them away? And it's not calling out people, it's not being mean to people, but it's identifying and addressing the issue promptly. And it's okay to have that conversation afterwards as well if it's needed. But if you don't identify it, then it's going to be seen as though it's acceptable, whether it is or isn't. So being able to intervene at those times, those are things that nurse leaders need to become comfortable with, to be able to do and be able to have those kind of conversations with people.
Yeah, really, what you're talking about is increasing a culture of accountability.
Yes, it's completely a culture of accountability, completely that part of it. Being able to have those conversations, being comfortable with having that conversation, that effective communication. Because again, for all the reasons we've already talked about, it increases, it makes it the best patient optimal care for patients, but also the best collaborative environment for your nurses. And if one individual isn't held to account, that spreads
Yeah.
very quickly and very easily. And there's a lot of research to show that part as well.
Are there any specific interventions or policies that can be implemented to prevent or reduce bullying or even incivility? You talked earlier about education, and maybe it's a great goal that is part of during someone's orientation process. Everyone goes through crucial conversations, or maybe it happens a year afterwards. I'm not sure if there's literature out there about the right timing behind it, but
Yeah.
beyond that education, that's just almost a one-time thing. How do we continue and sustain a continuous environment of not tolerating bullying and calling out incivility when it exists.
Yeah. So we as healthcare professionals have really embraced that thought process of zero is possible in so many different things, right? Zero central line infections, they are possible. Zero cubitus ulcers, they are possible. This is possible too. It is possible. But if someone is out there that can find that silver bullet to make it work everywhere easily, they would be a bazillionaire. There are multiple ways to be able to reach zero in this. And again, a lot of it comes with that accountability we're talking about, but there's not any one specific silver bullet for this. There are just multiple different types of interventions that go into play. And again, a lot of it is helping and making sure that the nurses at the bedside, the charge nurses, the managers, directors, all the way through, that they really understand that they are the ones that can speak up. They are the ones that are accountable for their acts, for what they do, and they can help to call out other individuals. Now, the educational part is simply to be able to, how do I have that conversation when I need to call someone out? And how do I respond when I'm being called out, right? Because that's another component of this. When I get called out, when I was telling that story initially, when I got called out, it took me back. My first lower brainstem type of thought process was to be mad because I'm getting attacked. But how do you respond to those kind of things? And that's part of the educational component that goes along with this. But overarchingly, to really decrease this and really help people to be accountable to that is we have to be able to lead by that example all the way through and be able to make sure that people do have the ability, do have the understanding, and do have the backing from others that when I am confronted by physician X or tech Z, whatever it is, that I'm not going to get busted down essentially or get yelled at because you cannot be mean to that physician. He brings millions of dollars to this facility and blah, 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 blah. Everybody has to be held accountable to that. And again, that starts from I definitely don't want to say top down because it's not just top down. It is bottom up. It is middle out. It is everywhere.
Well, the group sets the tone of what is going to be tolerated in the environment. The
Yes.
leader may set the overall tone or vision, but at the end of the day, the group decides to go along with it or set their own tone.
Yeah, completely agree with that. Completely agree with that.
Any closing thoughts as we wrap up this episode?
Nursing has the tremendous amount to play a pivotal role, whether it's emphasizing education or training, but it has the greatest ability to be able to really emphasize respectful behavior, conflict resolution, and essentially what becomes into emotional intelligence, quite literally. Having the ability to be able to understand what I'm doing and how it affects others, that is a component of EI. And since we are the biggest components that is out there in the healthcare field, we're the ones that really need to help set that tone. We need to be able to have that encouraging and open dialogue, not just with others, but also with ourselves, and be patient and be respectful of our thoughts and of everybody else's to help raise that awareness and overarchingly the accountability for what everybody does, including myself. Because again, that zero tolerance approach, that is possible if we all make that commitment, stopping and decreasing those inappropriate behaviors that do happen on a daily basis.
Incivility and bullying in the healthcare environment has been our episode topic, but in reality, what we're talking about is respectful behaviors and promoting a healthy work environment. Dr. Matt Howard, thank you so much. I appreciate your time today and our conversation.
I appreciate you asking and helping us to get this information out there for you. Thank you very much.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.